I had the, I guess, experience when I was transitioning from anesthesia to pain. I had a period where I had no X-ray machine to do epidurals and for the neck pain, for the pinched nerves in the neck. And I had to manage with what to do with these patients. And the most common thing I noticed is these patients would come in and they would say, I have a pinched nerve, and they'd put their hand right here. And what's under that spot is the brachial plexus, basically. You have supraspinatus, trapezius, of course, but you also have the brachial plexus. So I first started doing suprascapular nerve blocks on these patients, and I noticed a couple things. A, about 80 to 90% of them got better. And you could say, oh, that's the steroid you use, that's a systemic effect. Well, I would use less steroid. I use like 20 milligrams, 10 milligrams of depot. And maybe if that is the steroid, well, so be it. At least they didn't need to have a needle shoved next to their spinal cord. They would also tell me that their hand felt numb after the procedure, and that their hand or arm pain went away and their neck pain would went away. And this nerve does not go, as you know, it does not go to the hand, right? It ends at the shoulder. I am imagining, or I guess assuming, that the medication possibly tracks, I do the suprascapular nerve over here, not at the notch. So it maybe tracks to the axillary brachial plexus. It's doing a peripheral brachial plexus block. I don't know the answer, but it works. And you can avoid cervical epidurals for a lot of these patients. And for those who maybe don't respond to that, or if you want to be really a little bit more targeted, I then found that by tracing up from the interscalene brachial plexus to find the exiting nerve roots, you could put a little dexamethasone and bupivacaine or lidocaine or PRP, which we'll talk about in my other lecture later, at these regions, and get some very good outcomes. So 90% of patients with a textbook indication for cervical epidural do not get them in my practice, and they do fine. They do very well. And it's a less invasive procedure. Now you ask, well, Medicare doesn't pay for ultrasound spine procedures, so how do you do it? Well, every textbook I ever read shows that the roots are part of the brachial plexus, roots, trunks, divisions, etc. Okay, so here we have the interscalene brachial plexus. So the anesthesiologists in the room probably are very familiar with this. It's the snowman or the stoplight sign, right? You see the nerves just lined up. They're hypoechoic, they're black. They have more fluid content than the brachial plexus as you go more distally. And I even read an article where I wish I had the reference, but there's mention of CSF in these nerves. So that might be why there's a higher fluid content. That might be why this peripheral shot helps with the central herniation or problem. Who knows? Either way, I'm having very good results with this. And if you know, once you're experienced and good with the ultrasound, you should definitely consider it, because it's probably a lot safer than what most people are currently doing with the X-ray machine and the epidurals. So you have in the picture the anterior scalene and the middle scalene on each side of the brachial plexus. You don't see C8 or T1 here. It's really just C5, 6, 7, and sometimes it doesn't appear as a perfect circle because the nerves, they divide, they come together, if you remember from the anatomy books. Here is Chasternag's tubercle, this shadow right over here, or over there. And you have vasculature here, which you won't see unless you put contrast on when you go with the X-ray. With the ultrasound, I throw on Doppler every time because the nerve is black at this level. So you want to make sure this is not a blood vessel. So I capture that image, so I'm documenting, hey, I checked to see if there's a blood vessel here, because I'm not using contrast. And I record that for the chart so that if anyone ever questions me, I'm showing, hey, I'm looking before I leave. I'm making sure I'm doing the right thing. Here is the trachea, the thyroid. We're scanning the neck, the carotid, and then we're going to come more lateral. And to find the interscalene, just tilt your probe up like this a little bit, and you get a nice cross-section of the nerves. And they line up really nicely. I have these videos on my YouTube channel. Just type in pain exam, you'll see them. Or on the website. So as you scan upwards, you see the nerves, they're kind of disappearing into the frame, and they're losing their circular shape because they're turning. The ultrasound's picking up not the circle anymore, it's more of like an oval shape or amorphous shape. And they're disappearing into the foramen. And this is where I'm targeting my nerves.